Welcome back, everyone. I'm Cheryl Koehn, and I am the interview host for our chat with Dr. Mary de Vera. This is the #CArthritis booth run by Arthritis Broadcast Network. It is really my pleasure to be here with you this morning. Mary and I have known each other for a long, long time. She's an incredibly talented researcher and a force to be reckoned with in the happiness department. You're not going to meet a happier, cheerier, more positive person than Dr. de Vera. She is a Canada Research Chair in Medication Adherence. You have the Professorship of Adherence at the University of British Columbia. She is very active on a number of team grants, research grants funded by the Canadian Institutes of Health Research, and has a really broad base of knowledge and experience. We're going to talk to you about two of them this morning. We recognize that you are very expert in pregnancy and lupus, medication and pregnancy and things. We did talk to Dr. Amiri yesterday, so had a really nice session with her. So we're going to try to steer clear of that topic, not because it's not important, but because you have two areas that we particularly want to talk about and that relate to the things that you're doing here at this year's Canadian Rheumatology Association meeting. And so let's start with gout.
Perfect.
Yeah, so gout is, I actually think it's the most common mystery disease out there, and most people don't know it's a type of arthritis.
Yes.
Most people don't know that it's the one type of arthritis we can actually cure.
That's correct.
So I'm going to start with that lead and let you carry us on.
So yeah, gout is one of those, it's really cool to me because when you see some of the research papers on gout, they also have the cheekiest titles because it's like, it was historically known as a disease of royals because back in the Middle Ages, it was only royalty that could drink and eat the rich foods.
So they thought it was like the rich man's or the rich person's diet. Yeah.
Yeah. So then you'll see like these research headings. You know, there's the royal disease, but it's like it's the only disease that's curable. So it's like, you know, what's gout got to do with it?
Yeah.
So I love that area because you're allowed to be cheeky.
Yeah. Oh, love it. Okay.
Yeah.
Good.
But going along the thread that it is the only inflammatory arthritis where the cause is known. And that is, you know, when serum uric acid builds up and then it crystallizes and it leads to like the joint damage and the inflammation. So we know what causes the disease, and then we also know how to treat it. So there's serum uric lowering therapies that if taken as prescribed regularly, then it will, you know, effectively cure the disease.
Right, and it's so painful.
It is.
It's a really painful disease. And what are the common areas for gout to appear?
So the most common is the big toe.
Yeah.
So when patients have a flare, you know, they say that even the sheet on that toe is so much pain.
Yeah.
And when you think about your toe being in so much pain, that has so much implications for not being able to walk.
Right.
So it's really immobilizing when you're having a flare. But it also happens in other joints, the elbows.
But most commonly in the toe. Yeah. Tell us about your research into gout. What are you learning? What are you excited about? What would our audience, your members of the public and patients who are tuning in on our Facebook and Twitter live channel, what is it you're doing to uncover the mysteries of gout?
Okay, so one of the problems, there's two problems with gout. So one is that even though there's guidelines and there's quality care indicators, they're not receiving appropriate care.
Okay, patients aren't getting the right care. Okay.
So there's a problem on the care side. And then I never want to blame the patient, but with patients, there's also a problem with not taking the anti-gout medications as prescribed.
So adherence.
Adherence.
Yeah.
That word is tricky.
I know. People don't really like it, but it's we can't find a better one. What we call in our writings, in the work we do, Mary, we say sticking with it.
I like that.
Because it's positive.
It is positive.
And it also is a nice little reminder, a gentle reminder that if you don't stick with it, and people use that language in their other areas of their life, you know, boy, I'm going to accomplish that goal if I just stick with the work.
Yeah.
Well, it's the same when you take your medications. You get better when you stick with it.
That's true.
Yeah.
That's true. I like the positiveness.
Yeah.
Speaking of happy, putting a happy or positive spin on something, I like sticking with it.
So people who are struggling with gout have a hard time sticking with it.
Yes.
And do we know why?
Yes. So when we look at the qualitative literature, and actually we did our own interviews with gout patients who are participating in one of our studies. So one of the things is actually there's a dislike of medications.
Right. So just attitudinally. Yeah. Okay.
And then the other one is the fear of side effects.
Right.
And then the third one is actually being misinformed. So in our interviews, we found that, some participants said that, if they take more, like the front end, then they can go off because they've built up a store or like some immunity.
Which is a false. Yeah,
so
false. Okay.
So that's not taking medications as prescribed. So there's that information gap.
Okay.
Yeah. So so what we're actually doing is to address both, from the care side and the adherence side, is we're testing novel models of care and testing how electronic health technologies can support that. So one study that was funded by CRA, so CRA funded our study.
So CRA, thank you CRA for funding this study.
So it's a really cool study. We call it the Virtual Gout Clinic.
Okay.
And what it is, it's a decentralized care model. So the gout patients see the rheumatologist as needed, but that what we added to the team is a pharmacist, because again, medications are really important.
Absolutely.
Management of gout.
Yep.
And a dietitian, because there's so many diet modifications that you could also implement for gout management.
Fantastic.
So we added those two members, and then what we did was, can we use eHealth to support the care episodes? So our rheumatologists and then the patients that consented were brave enough to open up the EMR so that the pharmacist can call the patients and do a medication review. The dietitian can call the patients and do a dietary consult. And instead of, asking patients, oh, did you go fill your medications, or, did you do your labs, they can actually go into the EMR, see when medications were ordered, see when medications were filled, go to the labs, see if they had taken
their lab tests,
and then see what the lab results are.
Okay.
So that really facilitates that conversation, because you're not having to ask patients information that they don't have, and then they don't have to go to the rheumatologist.
So it's kind of like, if I'm hearing you, Mary, it's like you guys are in the background working.
Yeah.
You're like humming along, keeping the engine kind of fine-tuned from an information perspective on the patient.
Yes.
And the patient is consented to let you do those things with those records.
Absolutely.
I have to say, this to me, when we talk to our membership, our members are so frustrated that you guys can't talk to one another through our records. So this, I think, to a lot of our viewers, will be music to their ears.
I'm glad to hear that.
I think so anyway.
Okay,
yeah,
that's
and
good.
if not, you can email us or comment through Facebook and Twitter and let us know.
Yeah.
But for when you give consent, it's letting modern technology help improve our quality of care in gout.
Absolutely.
Yeah.
Because and then the other side too is this technology is present. It's supposed to support care.
Right.
So it's already being collected. So like the question that we wanted to ask is, how could we actually use that information? How could we use the technology? So we're not adding any burden to the healthcare providers. We're actually supporting how they provide care, because we're fast forwarding.
And you're not also asking the patient the same question over and over and over again, which we find very frustrating.
And cumbersome. And some of this is answers you don't have. Like, unless you write down your lab results and you wrote down when you took the lab, you won't have that.
Right. Super cool.
Yeah, and the other.
So did you present that at this meeting?
Yeah. So actually, there's going to be a poster 196.
Oh, okay. If you're at the meeting, go see poster 196.
Yeah, and the really cool thing about this study, which is also close to my heart because I grew up in northern BC, is because we're taking advantage of electronic health.
Yes.
We had rheumatologists that were based in Vancouver, but we also had some on the island. And the dietitian and the pharmacist were both based in Vancouver. So we were able to provide the service regardless of where the patients were.
So this could have really good application in rural and remote communities, which is really music to my ears as a patient and someone who's working hard to help patients who are living in rural and remote areas of not just where this meeting is taking place in Vancouver, but right across the country.
That's right.
Super cool. Okay, we're going to talk about, because you raised it in the gout conversation, we want to talk to you about your medication adherence work. Basically, I think as I probably really inelegantly said, medication adherence is a patient's willingness and ability to stick with it. So in general, what are the things, we heard fear of side effects, we heard you say, attitude towards medications. What other things underlie medication adherence and the flip side of that, which is non-adherence?
Yes. So we actually did focus groups with patients with inflammatory arthritis. So we didn't want to limit it to just any one. Right. Because it is not a disease-specific thing. It is a medication.
Absolutely. It's a societal thing.
It is. Yeah. It is. And that was also funded by CRA. So thanks
again,
to the CRA. So one of the findings, one of the themes is information delivery. Yeah. So one of the big themes was it would have been great if they had information right from the beginning.
When you say beginning, you mean when they picked it up at the pharmacy counter, or when it was prescribed?
When they were first diagnosed, that they were going to get the medication. So I guess there's so much going on at the time, but so that is the time to give the information that this medication is to be taken at this time for this long. Okay. Yeah. Okay. So,
because typically what happens is our doctors write our script. It's in handwriting. Usually we can't read. It's using jargon, PRO, like all kinds of technical medical professional language. Yeah. That we don't understand. And actually you're never talked about it.
No, not really.
Yeah. And then we go to the pharmacist and they put it on the bottle and it doesn't even make more sense. Yes. You have a really quick interaction with usually someone standing behind you, listening in on your conversation. Yeah. And that's it.
Yeah. So part of that conversation about the disease is also how to treat the disease. So, yeah. But, along the same lines, patients also told us that, it's the relationships with their GPs, with the rheumatologists, with their pharmacists that have really been able to help close that gap. Okay. So, and then some of them are talking even they go to a Costco, but having that one-on-one with a pharmacist, because there are, they want to go above and beyond. Right. They're all, healthcare professionals. Yeah. So I was really
Are you biased
excited.
in any way?
I'm not biased at all.
She's a pharmacist.
I'm not biased. So I'm not biased at all. Okay. But no, I'm not a pharmacist.
Oh, I'm in
the Faculty of Pharmacy.
Oh, you are? Okay,
but one of the things that we're promoting in our school is the roles of pharmacists. Yeah. And for patients to know that they are healthcare professionals, they are highly trained, use them, they're accessible. So we've done studies that shows that pharmacists are 7 to 8 times more accessible than your doctors. And they are medication experts. Right. So they will have answers to those questions.
Yeah, thank you. So in terms of medication adherence and in the work that you're doing, what other kinds of projects are you doing now or that you think you want to do to further kind of elucidate or shine a light on what's happening there? Because the cost of medication non-adherence is enormous.
It's 7 to 9 billion a year that was calculated, and these are old data from 1995.
And that's just in Canada?
That's just in Canada.
So think about what we can do with billions of dollars to improve the healthcare system. If in fact we're taking the medication that we decide on with our health professional, if we take it, there's a chance to save a lot of money.
Yes.
Because when you don't take it, as Dr. Esdale, whom we interviewed before you, explained that it's the cost of not treating disease that often is the far greater side effect than the actual medication. Yeah, that's interesting. Right. Yeah. And so what other things are you going to do to close that gap?
So I guess along the same lines of just flipping the narrative or changing the lens. So a lot of the work has focused on what non-adherence or not taking medications does. Yeah. And we all know that. It's expensive. It leads to complications. It leads to hospitalizations. So I thought, okay, well, why don't we show what good things
adherence.
With adherence.
I told you she was happy and positive.
So actually, if you're here today, poster 243, I have a pharmacy undergraduate student who did this as a summer project. We looked at what happens in SLE patients, lupus patients, if you take hydroxychloroquine as prescribed, And we're looking at additional beneficial effects. So we know the effects of hydroxychloroquine on lupus in terms of getting the disease control, but it's also actually been linked to beneficial effects on glucose metabolism. And there's been a population-based study that showed a protective effect of taking your Plaquenil, hydroxychloroquine, on the risk of developing diabetes.
So diabetes and SLE are quite commonly linked. So if you can do something to better treat and maintain the disease control in lupus, you also stand a chance at preventing diabetes. In lupus.
Yeah, so
that's amazing.
Yeah, so that's what that prior study showed. Yeah. So then I was like, okay, let's take it one step further. Let's look at the adherence. So then we applied, some calculations and calculated adherence, and we showed that the patients that do stay on, they have a almost 40% lower risk of developing diabetes.
That's amazing. Holy smokes. Yeah. Way to go.
Yeah. So
Fist bump on ABN.
Poster 243.
Poster 243. And the great thing is, you just gave this information before anybody else here gets to see it.
Am I allowed to do
that? The public got to hear it first.
Okay. Yes.
And we're so happy that you shared those results. I mean, that's staggering.
It is.
That sticking with your medication in specifically hydroxychloroquine in lupus in SLE has a preventative effect
on diabetes, which is a major complication.
Oh my goodness, it's significant. And I mean, we have a number of members across Canada who have lupus who also have diabetes, and some of the stories that we hear are heartbreaking about loss of disease control and now having to deal yet with another chronic disease is really you just don't want to hear those stories.
No, you don't. No.
You don't want to hear those stories. I'm going to say huge thanks. We're going to go to our audience for a minute and see what kind of interesting questions they're going to have for you, Mary.
So an audience member wants to ask, how can friends and family help patients adhere to their treatment therapy?
Oh, cool question.
That's a good question.
Yeah. Have you done any work in that area?
Actually, it's the focus groups also just talked about, friends and family do. So we have one participant said that their mother texts them every day. I mean, that's a lot of work. Did you take your medication?
Yeah.
But a lot of participants also said that, just having the friends and family go to the appointments, because then they could also be an advocates. And sometimes, patients hear so much information, then it kind of gets muddled in there, but having a second set of ears. And then you can ask the questions that the patient may have forgotten to ask.
Yeah. And in the active practice of then taking the medication, I can just add this. I used to be horrible at taking some of the things that I was supposed to be taking. So my husband at the time helped me. By Monday so we made Monday methotrexate Monday, which just having that little,
do you
mnemonic.
Sing the song? Methotrexate
Monday. No, we don't, but thank you. And we're going to take that act on the road next. Appearing soon at the, but that actually worked. And he would actually put the pills in a little cup and put them high. We didn't have any children, so didn't have to worry about, kids getting at them. He left them in a cup on the counter. He got up earlier than I did. And then he also did that for my NSAID. He did it for my vitamins.
Oh, wow.
Yeah, so we made it kind of like a daily routine.
Yeah.
And it was also a way to sensitize him to, okay, Mondays then I usually dealt with a little bit of upset tummy. So we were conscientious about what was in the fridge that would help me overcome a bit of that nausea. So it was a team, we made it a team effort.
I like that.
So actually families, so reminders, physically helping prepare the medications is always helpful.
I mean, for me too, like my experiences with meds that I have to take, my husband does all of the pickups at the pharmacy, so that I don't have to think about it. And his office is in the same building as the pharmacy, so he can just pop and say, oh, is she up for her refills? So just to take a little bit of that burden.
Yeah, because it's a lot to live with the disease to begin with, and then to worry about all the ancillary things around treating. but particularly with respect to adherence. And, you know, we're a pill-phobic society.
We are, yes.
We're, you know, the first thing you hear, I remember when I started to tell people I had rheumatoid arthritis and I had to take medications, the first thing I heard from friends, if I was at a cocktail party or in the gym, is, oh, I don't take anything. I won't even take a Tylenol if I have a headache. Well, these are diseases that are very significant, and without treatment, all types of treatment, by the way, not just medication treatment, pharmacologic and non-pharmacologic treatment. Without them, though, I wouldn't be here.
Yeah,
I'd be at home, incapable of leaving my home because I'd be in a wheelchair. So we want to thank you so much. Anita, any other questions?
Are there any workplace accommodations that can help patients living with gout?
Oh, that is a good question.
Yeah.
I'm not a workplace expert, though my colleague, Dr. Diane Lakai, is an expert.
Okay, so we can go and check with Diane Lakai, Dr. Diane Lakai, and see if, in fact, there are specific workplace initiatives related to gout. There are for other types of arthritis, but gout, I mean, it would make sense that there should be because of the severe impact it has, significant impact, rather, on one's mobility.
Yes. Yeah.
And so if you're having a very difficult time getting to and from work, there's probably some basic workplace principles that would apply to gout as they apply to other types of arthritis. You know, telecommutes, remote working, work from home, job sharing, like things like that, of course, are probably applicable, but specific to gout, we don't know, but we'll find out for you and let you know. So, Mary, on that note, we thank you so much for the time. Congratulations. I know. I told you it would be fun. You have fun wherever you go. And now we have a singing duo, so we're going to have to take that on the road, our Methotrexate Monday song. But we really thank you for all the hard work you do on behalf of patients. We look forward to talking to you at next year's meeting and learning about the progression of your research. So thank you very much.
Thank you.
Yeah.
Thank you.
Bye. Thanks, everyone.